Assalamu alaikum. Good afternoon, Jum'ah Mubarak, inshallah. Thank you for being here today on a Friday. I think today is one of the trending and interesting topics that we have been talking about recently and more focused on because of its importance and because of its how much it affects our healthcare and our patients. And it's interesting because it's one of the topics that actually gathers us physicians and healthcare practitioners from all specialties. When we talk about patient-centered care and we talk about the involvement of the multidisciplinary team and the multi-specialties focusing on the patient care, this is one of the main examples for that. And you can see that today, and I'll introduce our speakers very soon, come from very different backgrounds, but that's all to help our patients. Without further ado, I would pointer, please. Yes. Just to start, my name is Walid Al-Habib. I'm a consultant cardiologist and the current president of the Saudi Heart Association. And this is my disclosure. The topics we're going to talk about today, although talk about adult vaccination in general, but we're focusing on the specific vaccine, the recombinant zoster vaccine. So we're going to talk about prevention in the context of the Saudi healthcare transformation, shingles disease burden and complications, shingles in high-risk adults, why comorbidities change the equation, when shingle intersects with chronic conditions, prevention as part of chronic disease management, and Shingrix, evidence designed for patients with elevated risk from recommendation to routine practice. Our speakers today are well diverse, as I said, but highly experienced in their practice, starting with Dr. Ra'ed Al-Dahash, who is a consultant endocrinologist at King Abdulaziz Medical City National Guard, Riyadh, and the head of scientific committee in National Center of Diabetes in the Saudi Health Council. We're also having with us today Dr. Jawahir Al-Ataibi, who is a consultant in infectious disease at King Faisal Specialist Hospital and Research Center in Saudi Arabia. With us as well today, Dr. Raneem Miliani, who is a consultant internist and geriatric medicine at National Guard Health Affairs in Riyadh. And last but not least, we will be having with us also Dr. Dan Al-Mu'abbir, who is a consultant in diabetes and family medicine at King Salman Hospital. So I'm pretty sure their experience will add a lot to the discussion today and give it a fruitful outcome, inshallah. So the first topic, as we said, is prevention in the context of Saudi healthcare transformation. So starting with what I thought is the most difficult question in the day, but Dr. Ra'ed is one of the best to cover it. So Doctor, in your practice, what structural or operational changes have you seen that reflect our progress towards Vision 2030 goals?
First of all, thank you, Mr. Chairman, for your nice introduction. And thank you for our colleague in GSK for the invitation. I think this is one of the important questions, and it's not easy question to be answered, to be honest with you. As you know, the transformation is one of the part in the 2030 visions that it's in our country, they focus on it, and they want to change a lot of things in healthcare system to this program. So the transformation, I mean, focus on healthcare system to be more comprehensive, more effective, more integrated. Then they want to make it priorities for innovation, financial stabilities, and also the disease prevention, as we talk today about it. In the future, in the previous, they focus on treatment of the diseases, but nowadays they try to be moved to prevention, which will decrease the cost and it will be improved for the patient. As you know, the prevention is better than treatment. Then also they will be focused on, they expand in e-health services, digital solutions. Nowadays we have صحتي applications that everything, every labs, you see it there. You can choose for your appointment. You can also choose the clinic that you want to go, for example, vaccination clinic or appointment clinic or whatever the clinic that you want to choose in a health system, which is easy for the patient. And he can choose also which center near to him that he can take appointment today or tomorrow and the time that he will have it. Also, they want to improve the quality of care and to make international standards. One of the problems that we face it nowadays in any disease or in any problems that we have it in our country, we don't have standardizations and we don't have a protocol that unified. Some people, for example, they will follow Americans, some follow Canadian, Australians who have international standards for everybody of us to follow the standards is one of the part in the vision to make it very easy. Also, they focus on the standard quality of healthcare services. They will be focused on quality rather than the quantity. So they will have quality clinics, quality measures to make sure that everything going in the right direction. Then after that, to focus on the results. Then in the public sector also, they will have collaboration and integration between health and social care, because I think health and social care is very important. Also, they will try to be moved to another system that they will be more focused on the people to be participated more in social activities, in other social commitment, I think, in our country. So rather than to have a treatment, no, they will focus on HCP education plus minus to be for public people to increase their awareness and increase disease. Then after that will lead to more preventions and will make the system easy for the people. Then after that will make it an outcome for our healthcare care system in our country.
Excellent. No, I actually noticed that, as you said, the standardization of care is always difficult, and probably because of the multiple health sectors that we have. So it's nice today that we're having someone from the university, National Guard, we're having King Faisal, the Ministry of Health. Maybe this is a start to unify our practice and do it one. The Saudi Health Council is part of this, and hopefully that will help a lot. So moving on to the second question, Dr. Jawahar, what gaps do you find most challenging in your current practice, and how can Vision 2030 overcome them, please?
So, Assalamu alaikum and good afternoon, everybody. I'm very delighted to be among the distinguished panelists today, and thank you, Dr. Walid, for the kind invitation, and also GSK for giving me this opportunity to be here today. So I can summarize that the challenges in the healthcare sector as three domains, like a disease burden, access and quality of care that is delivered, and system infrastructures. So unfortunately, we have a growing burden of chronic diseases in the country as in comparison to the Western country. When it comes to access and quality of care, so the access services and quality of the care that is delivered is very variable across all regions. And that is also can be translated in suboptimal utilizations of the primary care with unequal or variable quality of care that is delivered in these systems. Another thing is the digital or the systemic infrastructures. And until today, the digital systems of the Saudi is still evolving. We don't have yet a very unified digital system that we can gather all the information from it, or can also track the clinical activity access, the outcome, and the cost. Efficiency, we do have low productivity in the services that is delivered, and also we do have, on the other hand, increasing healthcare expenditure that sometimes outpace the growing economic status. So these are the challenges, or collectively, that explains the urgency for the Vision 2030, which mainly aims to improve the integrity, the efficiency, and also the sustainability of the healthcare system in Saudi.
Excellent. Now, I'm hoping that the move towards the Vision 2030, which is very fast, actually, alhamdulillah, in our country, and we have achieved a lot in it. Healthcare is probably picking up in that, can overcome these challenges. Because, as you said, it's very important to have the access, to have the follow-up, to have the care, and it's one of the major targets of our transformation is quality of life.
Yes.
And the human being, the center of this, and without the health, it will not be. So definitely. So before we go on, we have a polling here. Did we have a code? Did we the screen, the code, the barcode is already there? Okay. So people can answer. Which of the following is a key pillar of the Saudi healthcare transformation aligned with Vision 2030? So let them scan it and go back to the question again, please. So please scan this code. Can we go back to the question, please? No, go back to the question so people can answer. Yes. So which one do you believe is the key pillar? Focus on curative care over prevention, integration of care, and emphasis on prevention, reduction, digital health adoption, limiting access to specialized service. Limiting, that's interesting. Okay. So show us the results, please. So how many answered? Yes. Okay. So mostly 74% got it right. Integration of care and emphasis on prevention. That is the primary goal. Okay. All right. Next. Okay, so shingles disease overview. Let me move on to Dr. Dana. Can you tell us more about herpes zoster infection and why doctors should care about it?
Assalamu alaikum. Thank you for everyone showing interest in attending, and thank you for having me with you guys. First of all, if we're going to talk about herpes zoster and the infection, herpes zoster is usually the reactivation of the varicella zoster virus. And usually this kind of virus happens through multiple phases. And if we're going to talk about the first primary phase, which is in the childhood period when it appears as chickenpox, and that we're all familiar with. And then it goes through a latency period where it's stored in the dorsal root ganglia. And then due to many multiple factors, later in life, whether it's because of aging or changes in the immunity, reactivation will happen. And this is when the shingles appears or the herpes zoster reactivation is happening. And it's usually appearing as a unilateral rash and pain. So if we talk about what kind of rash or what's so characteristic, because whenever we talk with our patients, they do have a previous history, whether they've been through it or a relative or a dear friend that had suffered from it. And it's usually a unilateral dermatomal distributional pattern of rash. And there are more common dermatomes that can be affected. So mainly the thoracic, having by around 56%. And later on, you could have the lumbar, the cranial, cervical, or the sacral. And if we talk about the cranial part, you know, the most striking thing that we don't ever want to see our patients having or going through is having their cranial nerves or distributional parts like the ophthalmic division of the trigeminal nerve. When it's affected, we know how catastrophic that can be for patients. Another thing is, that's like talking about the great scenario of the disease, but unfortunately, if we have immunocompromised patients, and fashion of the disease can be different. It can be in multiple dermatomal distribution, like vesicles can happen in 2 or more contagious unilateral dermatomes. Unfortunately, it can present as bilateral, or it can be presented as a disseminated, because at least 20 vesicles can develop systematically within just a week of having the rash. And unfortunately, there's a risk also of necrosis, especially if we're talking about the head and neck region. And unfortunately, there's also a risk of infection, which is almost like 2.3%, that patients have reported cutaneous lesions within only 60 days of developing the rash. Again, about immunocompromised patients, it's about the lesion. There's prolonged formation, larger, it's more numerous. And the distribution, as I said, it can be unilateral, multiple regions, or it can be bilateral. And also the atypical distribution is common with them. And unfortunately, the complications, due to the immunocompromised status of the patient, the complications, as in we're talking about viremia, pneumonitis, hepatitis for patients, post-herpetic neuralgic pain, unfortunately, is the most common complication. And also, they are more likely to develop a recurrent attack of herpes zoster. So it's not just once, it can happen again for patients.
Thank you, Dr. Dana. So, Dr. Raneem, data suggests that 1 in 3 adults will have herpes zoster in their lifetime, and the risk increases with aging. In your practice as an internist and geriatrician, does this align well with your clinical experience?
Okay, thank you, Dr. Walid, for this question. This question actually is very personally for me as a geriatrician. A long time ago, before practicing as a geriatrics, or when I was a medical student, I was thinking the shingles is underestimated. Now, as a geriatrician, taking care of older adults, seeing them in my clinics, seeing so many patients, even in the inpatient for the older adults, I think it's actually, I was thinking it's overestimated. Now it's actually underestimated. We see it a lot in our practice. I take care of patients who are 65 and above, and those kind of patients, they have so many comorbidities like hypertension, diabetes, chronic kidney disease, ischemic heart failure, and so on, COPD, asthma, and every single comorbidity is an accelerator for the disease and a risk for the shingles reactivation. So the question would be, is not that they would reactivate, it's actually when. And looking at the shingles, the age itself is actually an increased risk for them to reactivate the disease, the varicella zoster virus. And looking at the data, looking at patients, around 1,000 patients in primary care healthcare data, more than 90% were older adults that are 50 years of age and above who had varicella zoster virus. So probably those population will have a reactivation at certain points. And if you look at global data, if we look how many patients or the incidence, the epidemiology of the shingles, globally, you can see that there is every year a 1 million incidence of cases in the US, 1.7 in Europe, and 1.5 in China. And if we look at our local data, we can see that in the elderly population aged 50 years and above, 44.5% of shingles patients in Saudi Arabia, they were identified to have that incidence. So Shingles can happen in the older adults. Age itself is a risk, and the complications also increases with aging. Patients who are in the 65 and above and get shingles, they're more higher to get the complications as post-herpetic neuralgia, which is the most common complications that they get. And if you look at the data here by age group, you can see that by age of 50, the numbers will grow higher. And by age of 70, it's double the numbers of complications in the Germany study, exactly the same in the US study of the herpes or post-herpetic neuralgia. So what about our local data? In Saudi Arabia, what happens? Again, we said that the shingles, the elderly population of 50 years and above, they will have 44% of them getting shingles with age. And moreover, when we looked at the National Guard data for a study that was published in 2024, for Dr. Farhat, actually, he's a colleague, he looked at the patients retrospectively from 2017 to 2022, and the average age of patients who had shingles were the age of 53 years. So that's around exactly the same age where you see the most common cases happening. And if you look also the pre-existing comorbidities, the accelerator, the comorbidities that increase their risk of having the reactivation, at least they would have 7 out of 10 patients, they would have at least one existing comorbidities. And the most common comorbidities they've found is hypertension, diabetes, and hyperlipidemia. And if you look at the complications, 3 out of 10 patients, they have experienced shingles-related complications. And the most common, again, it goes along with the same trend. The most complication is the post-herpetic neuralgia, which is 18%. 6% of the population, they had disseminated disease, and the other 6% they had were the herpes zoster ophthalmaticus. And every year when they looked from 2017 to 2022, they've seen a trend of going more incidents of shingles on those population that they were looking at in the MNGHA. And they looked actually in the inpatient and they looked in the primary healthcare settings. So it's all over the hospital in 5 regions. So patients 50 years and above, they were 1.5 higher likely to have post-herpetic neuralgia and 1.4 more likely to have more severe complications of the shingles disease itself. And when they looked actually at the cost of hospitalization, all over the 6 years, it was like around 2 million riyal of cost because of the complications and hospitalization at MNGHA. So it's definitely going back to your question, Dr. Waleed. I agree. Yes, it's 1 out of 3. It aligns with what I see in my clinic. And to let you know, I mean, with older adults, the odds are even higher.
I'm glad that we are realizing right now how important it is. As you said, that we used to think it's a rare thing, and it was underestimated. So now let's take another polling question. Which of the following best describes the lifetime risk of herpes zoster? Now, I think it's hot out of the oven. We just said it. So if anyone gets this wrong, can you put a code? Back to the question, please. Yeah. Okay, the answer? Come on. Come on. You want us to repeat it all again? I'm gonna highlight. Go. Give me the mouse, please. Give me the control. Yeah, I want this to move. Yeah, I want to go back. Please. 1 and 3. Those who it said 1 and 4, 1 and 5 should not go for lunch today. Okay. So back to you, Dr. Raed. What are the most common complications do you see in patients with herpes zoster in your practice?
Thank you so much for this, I think, important questions. As you know, the complication of herpes zoster, it's from head to toe. There is a lot of complication, maybe as my colleagues see in the screenings. But usually the most, I think, important one and bothering one for the patients, usually the PNH, it's one of the painful situation that the patient, up to 30% of them, they start to complain of it. As you see here, there is a lot of other complications like ocular, vascular, cutaneous, and other neurological complication, if you see it in this graph. So it's a lot, but I think one of the most painful one is a pain. Pain is one of the major problem for the patient when it came to herpes zoster. So 10% they are experienced for more than more than one equal non-painful complication. So this rate, as our colleague said, it will increase with the age. So more increase in age, the more they will have the pain. So if we try to see how the nature of this course of this disease, usually the nature came in multiple phases. The first phase, usually it's from 4 days to 2 weeks. Usually the patient, they will complain of headaches, photophobia, malaise, and abnormal skin manifestations. Then after that, pain and fever. This is maybe the patient will not know exactly what he have, and he not, sometimes maybe he's not visiting the doctor. Then after that, the acute phase, it's after 2 weeks, from 2 weeks to 4 weeks, it will be unilateral, rash, and usually associated with acute pain. Usually in this phase, the patient start to seeking for medical advice and try to see the doctors and try to look what he have. Then after that, the subacute phase and can be up to 3 months. And those usually 5 to, let us say 30% of the patient, they will suffer from this chronic complication, unfortunately. Again, back to PNH, which is one of the most common complication of herpes zoster. It's neuropathic pain that usually persists more than 20 days, so more than 3 months after the onset of the rash. So this is one of the major problem. Usually the patient, they will complain from this problem. Then after that, due to the aging population and development of immunocompromised condition with the age, as you see here, so the percentage of herpes zoster usually followed by the PNH almost doubling after age of 70s. So more increase in age, the pain, it will be more. And as you know, nowadays in our country, in the vision, they will, one of the part that they will increasing the age. Maybe in previous years, maybe 50 or 60 or more years, usually the people, they die in middle, let us say 50, then after that, it will be increased. Maybe nowadays, we reach 80 years old, the median, 79 point something, so it's almost 80 years old, the people, they will reach this, which is, we want their quality of life to be good, and we want to prevent all the diseases that the patient may have it with increase in the age. So rather than to have a problem and complication and disease burden. So as we said before, the PNH usually persistent for months to years after the onset. 70% of the patient, they will report very clinically significant pain. So they, out of 10, when we ask the patient, they said this pain is 8 to 9 out of 10 with severity of the pain. So it's very severe pain. And usually the patient try to, if they can, try to overcome this problem to taking the vaccination and take this prevention. Maybe some of the famous people, they go, when they have this disease, they come in the social media, they talk about it. They said, please guys, talk the vaccination to prevent this severe pain.
Okay. Another question. Which of the following is the most common complication of herpes zoster? Again, if you didn't give that message, show us the barcode, please. The QR code. Yes, scan the code, please. back to the question. If you don't get it all right, I'm going to leave. Show us the answers, please. What was this? This is 4% to 9 to at least, yeah, the majority are awake. Majority are awake. All what we talked about was post-herpetic neuralgia, by the way. Okay, so B, post-herpetic neuralgia. Okay, now let me ask you a question. Just a show of hands, how many of you had a patient or a relative with post-herpetic neuralgia? I had a relative, it was devastating. Really, the pain is terrible. And that probably takes us to the important question, Dr. Ranim, how does post-herpetic neuralgia affect the quality of life in these patients?
I think you just said it
Yeah.
was a horrible, horrible experience. So post-herpetic neuralgia does really affect the quality of life. I usually say it's a hijacker for the older adult population because, you know, it steals the sleep, the mobility, the quality of life. They prevent them actually the pain from attending social events, to participate on a daily activity, doing their daily activity because of the pain. I've encountered patients who they come to my office and they say it's a burning sensation, it's a hot sensation, which is the most common. More than 76% of the population on the McGill survey that was done describing the pain. And 60% they would say tingling, itching, stinging. 50% of the population they would say jumping, flashing, pulsing, boring, stabbing. But again, the most important part is the quality of life for the older adults, for the patient themselves. We say in geriatric, it's a cascade of events. What happened exactly is the patient would have pain. That pain will make them independent. Instead of becoming independent, more independent when they have more good, healthy quality of life, they become dependent. They become immobile, they become deconditioned, and because of deconditioning, they become frail, they have fractures, they fall, they become hospitalized, and the morbidity and mortality will increase, and therefore the quality of life will definitely be affected. If you look at the data here, you've seen that across every aspect of quality of life, from general activity, from mood, from walking ability to normal work, to social relationships, to sleep, to the environmental, from the herpes zoster pain itself and the post-herpetic neuralgia complication, they does affect every single domain of quality of life. And 21% of the respondents reported high interference of their overall quality of life because of the pain. So this is really, really affecting the patients who get the herpes zoster. And the frustrating part is the medication that we give to the patient for the geriatric population, they are listed on the Beers list of medication. These Beers list is the American Geriatric Society, that they say this kind of medication that we try to prevent and not to use in the older adult population. So we treat a problem, but we're creating another problem. So first of all, think about the prevention, how to prevent the disease rather than treating the complications and the disease.
I agree. Great. So now, as you said, preventing the disease from the start is probably the best. But Dr. Jawahar, do we still see recurrent cases even after the initial involvement of these patients?
To answer your question simply, Dr. Walid, yes, we do see. So there are several studies that look into the recurrence rate of the zoster even after the first attack. And one of them was very interesting. It was run over 43 clinics in the dermatology from a period of 2005 or 3 to 2015. And around over a 30 plus K individual has participated in that. And one of those who exposed the recurrence out of the 16 over 16,000 of them who responded to the questionnaire, 6.4% of them does have a recurrence of the herpes zoster from the first initial attack. And surprisingly, most of them, they might have the recurrence in a different dermatome from the first dermatome that they present with, and around 16.3% of them have the recurrence on the second or third time in the same dermatome. The timing of reactivation was very variable, as short as 2 months from the first attack and as long as 70 years from the first attack. And most of them, of the one who had reactivation, was a female in comparison to the male. So the recurrence rate has been established in the literature, and it's several retrospective studies that look into the association between age, comorbid diseases in relation to reactivations of shingles. And surprisingly, those younger population at whom they have multiple comorbid disease or immune suppressing status, they do have a higher rate to develop a recurrence of shingles. Especially those populations, the highest were 18 to 49, followed by 50 to 95. And as Dr. Raneem, Dr. Adana illustrated prior, also higher population or higher age senior population, they do have also a high recurrence rate from the shingles. CKD, diabetes, chronic cardiac disease, or CKD, they also have a 30% higher chance to develop a recurrence zoster.
Excellent. So, Dr. Raed, what proportion of post-herpetic neuralgia patients achieve control, and how long does management last? Dr. Raneem has already touched on the challenges of treatment anyway. So, how can you
Yeah, I
control
think
it?
this is very important question actually. But the problem is the effectiveness of antiretrovirals therapy in prevention, the post-hepatic neuralgia is limited in clinical studies. So if you try to see here, 94% of the patient you treated with antiretroviral, 50% of them, they having the pain still experience during 12 months after the diagnosis. So it's still they having this pain even after they treating of them. So more than 50% of them. And unfortunately, the PNH also, this pain, it's persistent more than 3 months after the acute herpes zoster rash. So it will continue there, and 50% it will not be improved. That's why when we talk about the prevention, we talk about it very seriously here, that usually the pain will continue and will not be improved even with antiretroviral viruses.
Unfortunately, that's true. So, Dr. Well, before we go to you, let's go for this polling again. Which of the following best describes the impact of post-herpetic neuralgia on patients? Show us the QR code, please. Scan the code. Back to the question. Again, which of the following best describes the impact of post-herpetic neuralgia on patients? Mild and self-limiting, short-term discomfort only, chronic pain affecting quality of life, no significant impact. Answer, please. Okay. And yeah, هم نفسهم اللي نايم خليه نايم لا تجاوب. So it's definitely now, if you think that post-herpetic neuralgia is mild and self-limiting, who's moving? Yeah. Then please change your mind. It's severe pain and it affects quality of life significantly. Thanks. Okay. Dr. Jawahri, you touched on the importance of comorbidities in the recurrent cases and the cases. What are these comorbidities and how does it affect the herpes zoster population?
So most of the time, we rarely face a patient with only one comorbid disease. So most of the time, they will have diabetes, chronic kidney disease, cardiovascular disease, and other, for example, liver disease. So multiple comorbid diseases or presence of a one comorbid diseases puts a patient at a higher risk to develop reactivation of the shingles, and this will also have a result on the management of the underlying comorbid problem. And we do have available recombinant vaccine that has a high effectiveness against reactivation and the risk of also having a post-herpetic neuralgia as a complication. To further illustrate this, the viral infections and the comorbid disease has a bidirectional relationship. So comorbid diseases per se will put the patients to be more prone or susceptible to have a viral illnesses. On the other hand, the viral illnesses such as the zoster, the influenza, the COVID, and the RSV has a pro-inflammatory and inflammatory action. So there are a lot of cytokines that will be released, including interleukins, tumor necrosis factors, and other that affect the integrity and stability of atherosclerotic plaque. And that can result in either a cardiovascular thromboembolic events in those patients who, especially those who had an underlying cardiac disease. So it puts them at a higher risk to develop myocardial infarction. And due to the effect of the high cardiac demand during the viral illnesses, that also puts them at a risk to develop heart failure in relation to the viral infections. So looking collectively or independently to some of the comorbid diseases and their association and zoster reactivation, so having more than one comorbid disease put them at a higher risk to develop reactivation. So for example, in most of the studies that look into that, having a diabetes and a cardiovascular disease put the patient at 16% higher risk to develop reactivation of the shingles in comparison to diabetes alone. Having cardiovascular or lung problem, it puts them at a more than 25% risk to develop reactivation of the shingles in comparison to patients who had one comorbid disease such as diabetes or even COPD. So to summarize it, whenever you have more than one comorbid diseases across all ages, they have a higher chance to develop a reactivation of the shingles or zoster. Looking to diabetes alone and as independent risk factors in relation to the reactivation of zosters, in one of the meta-analyses that look into globally what is the rate or the risk of having shingles in diabetic patients, and it reaches as high as 38%. In one of the analyses that look into the US surveys of over 51 million diabetic patients, they have a 45% chance that they will develop reactivation or zoster infection. So comorbidities with shingles. It will be touch bases with Dr.
Yeah, thank you, Dr. It's nice that you highlighted, and diabetes is a major problem in our community, definitely. And Dr. Odana, dealing with diabetic patients in the diabetes setting, how often do you encounter herpes zoster, and how much does it affect the glycemic control?
Well, thank you for the question. Regarding diabetes, we all know it's one of the very common comorbid or chronic diseases in our country and worldwide. And if I can just state how is it related, we can just say it's a two-way relationship, because diabetes is a risk factor for shingles, and shingles with diabetes make diabetics' life harder. So if we talk in numbers, starting with in Saudi Arabia, around the herpes zoster cases, around 21.5% are diabetic, and it's the most common comorbid of herpes zoster infection, unfortunately. Around 19% of diabetic patients with herpes zoster suffer from post-herpetic neuralgia, and also 18% of them have increased risk of persistent pain or post-herpetic neuralgic pain for almost 6 months at least. So we're talking about more of a miserable life and a longer period for that. 63% have risk of hospitalization, and if we talk about hospitalization, we know what kind of a cascade of events comes with that. Again, if we're talking about it's a two-way relationship. Now, if I say a diabetic patient that got herpes zoster, what happens to them? The glycemic control or the glycemic status of the patients gets deteriorated. That's the unfortunate thing. So we can have a very well-controlled patient with diabetes, and then because of having herpes zoster, they can go through uncontrolling through A1C, And around 24% of those patients experience an increase of A1C. So the impact, whether we're talking about in the duration or in the management, whether we're talking the A1C control, as I said, 24% of patients that were previously controlled, they became uncontrolled. And uncontrolled patients means that they have a change in plan of medication. Some patients might need the introduction of insulin or other therapies of management to get them controlled, the length of stay, and also the hospitalization.
Thank you, Dr. Adana. So on the same line, Dr. Raed, why is herpes zoster prevention important in cardiometabolic disease, especially in diabetes?
Yeah, thank you so much for these questions. As you know, I mean, we are one of the endemic area for diabetes. We have a lot of patients with diabetes. There is multiple studies done in our country talking about diabetes. One of them, they talk about more than those people above age of 30, 25% of them, they diagnose of diabetes, and another 25% of them, they are either pre-diabetes or diabetes. So 50% above age of 30, either having diabetes or pre-diabetes. So diabetes care in our country, diabetes patient in our country, it's a lot. We have more than 5 million people, they having diabetes. The problem is not diabetes by itself. The problem is the complication of diabetes, or the patient when he get complication or infection, they having diabetes. So if you to see here in the studies, they said there is 19% increased risk of PHN in patient with diabetes versus in those patients with non-diabetic. And also the risk of the persistent PHN in those patients with diabetes, also 18% increase for non-diabetes. Also, they look for type 1 and type 2, almost the same. There is increased risk of PNH comparing in both groups. So this is taking for us that those patients with diabetes by itself, it will increase risk of the complications in general, and one of them is PNH. And also, the problem is it's not only by that, also the diabetes patient, they will have long of stay when they are hospitalized for herpes zoster, almost 3 more days in hospital comparing with non-diabetic patients. So, and also the hospitalization risk increased significantly with the aging, especially with those their age 70 years and above when they have diabetes. There is a lot of studies talking about that those patients with diabetes, when they get admitted, the complication after the admission, it will be high. And usually before any elective admission, they send to us to have a clearance for them. Usually we don't clear any patient if their hemoglobin A1C high or their blood sugar is high to prevent the complication post-op. The problem in the infection, it's not the time to choose when the patient having the infection. Usually the patient, they will have infection regardless of their blood sugar. And usually they have more infection if they have more uncontrolled in their diabetes.
Okay, thank you very much, Dr. Raed. Now, a question. Patients with diabetes have what relative risk of developing herpes zoster compared to non-diabetics? Shall I tell them the answer? If they will answer it right or not. Show us the code, please, the QR code. Back to the question.
Dr. Walid, you allow me for comments if you. I am a staff in university. I'm associate professor in university. So always I told the student, if you have multiple choices, no, always don't choose none of above.
Yes.
This is rule number 1. Number 2, if you have, for example, 2 numbers, 30% and 100%, one of them will be true. Yeah. So others, it will not be. And all of above, go for it always.
Go back to the question. So, no, don't show the answers yet, Mustan. Now, I hope no one adds no increased risk. And it won't be 100%, right? It's either slightly decreased, but is it a decreased risk? Do you think someone will have a decreased risk of developing, relative risk of developing compared to non-diabetics? So the answer is C. Yeah, show us the answer. يا الله. انتوا ما تعرفوا تغشوا حتى. Okay, it's 38%. طيب. Dr. Jawahar, this and the same line with comorbidities as common as diabetes in our community. Unfortunately, cardiovascular disease is common as well. So, why do you think herpes zoster prevention is important in cardiovascular disease patients?
So because of the bidirectional relationship that we spoke earlier about, so cardiovascular disease affected individuals, they have a 30% chance of reactivation or developing shingles with the cardiovascular event. And this will also result in a more complication in dealing with those populations that the viral illnesses, especially shingles, can trigger them or put them at a higher risk to develop either a cardiovascular event or a heart failure in comparison to the rest of the population. And this is usually in the first few months after the shingle or the zoster. Talking about also the bidirectional relation and the atherosclerotic plaque instability, 78% of those patients who have zoster ophthalmicus, they have a chance to develop stroke after the first or the initial episodes of the zoster by 78% in the first 1 month. Those with underlying cardiac disease, they have a 25% chance that they will develop a myocardial infarction in the first month after the infection. And also we have 22% of those with underlying cardiac disease, they might have arrhythmia in the following 2 years from the zoster reactivations, and a 14% of developing a coronary vascular disease related complication in the following 2 years from the first reactivations of zoster.
So we're probably going to touch on heart failure somewhere else, but it does increase all cardiovascular diseases, stroke, MI, and arrhythmias, as well as heart failure, and bidirectional, as you said. That's very important. So, Dr. Raneem, tell us more, please, about the infection and cardiovascular diseases.
For the cardiovascular disease, from long time ago, we always know exactly how pain from the herpes zoster, from the shingles can happen. But for the cardiovascular disease, nowadays, we are capable of understanding what's going on and what happens as a complication. So basically, if the varicella zoster virus reactivated in the sensory ganglia, it can actually travel along the nerve fibers. And it can go to the arteries for the cerebellar or coronary artery, for the heart arteries. And this can cause inflammation, increased inflammatory markers, autonomic dysfunction, and vasculitis. And this will lead to the cardiovascular complications from MI, arrhythmias, and for a stroke for the brain. So based on the studies, they did show that 34% there is an increased odds of events of stroke in the shingles after 3 months, and 35% increased risk odds of MI within 30 days after shingles. So this is exactly the complication that might happen after a shingles in a patient who was older adult and 50 years and above.
Yes. So interestingly, inflammation now per se has been implicated as a pathogenesis of cardiovascular disease, and infection is probably one of the most common or most clear causes of inflammation in the body. So again, back to you, Dr. Jawahar, on more cardiovascular disease. I think that's probably the best part of it when we talk about cardiovascular disease.
Okay. So talking about, again, because our main topic for the 3 of us onwards, we're talking about the cardiovascular link with shingles. And just a reminder, shingles is not just thrush and pain. It has a deeper connection and a deeper risk for the heart. And if we talk about the incidence of herpes zoster associated stroke, it's also, it's according to the follow-up and incidence increases with age. So we're talking about the older the patients that are suffering from herpes zoster, the more the risk they're going to get. And you can see through multiple studies that, especially with the risk in patients that are above 50, and the absolute rate difference ranges from 1.3 to 14.7 per 1,000 person per year. Again, herpes zoster is associated with MI, and you can see, according to the incidence, is increasing also with aging. So we're talking about the older the patients that are getting this kind of virus and the complications, the more the risk they will have with the cardiac complications. But also, if we think about having a diabetic patient or a patient with renal dysfunction who had the unfortunate event of getting herpes zoster. Herpes zoster shingles here works as a multiplying risk factor because we can see that diabetic patients have a 54% increased risk of having acute coronary syndrome. So just keep it in your mind. If your patient is diabetic and he has got shingles, then he has more the risk of a 54% increasing risk to develop acute coronary syndrome, unfortunately. And also if your patient is a renal disease patient and also having shingles, this is a multiplying risk factor because they're going to have around 44% of developing acute coronary syndrome complications.
Okay, thank you, Dr. Dana. Again, a polling question. Now, this is a little bit more tricky. Based on evidence earlier, how does herpes zoster infection impact the risk of cardiovascular events, MI, stroke? So show us the barcode, the QR code. Scan, please. Go back to the question. Still scanning. Question, please. Okay. So as you said, no increased risk is the wrong answer. Okay, show us the answer. Exactly. So at least the majority here, 58%. And so 34% increased in cardiovascular disease. Okay. So continuing to cover other chronic diseases, Dr. Raed, what about kidney disease? How is herpes zoster prevention important here?
In herpes zoster, actually, and chronic kidney disease, it's bi-directional association. So I remember here the Prophet Muhammad hadith when he said, if one organ of your body affected, automatically the other will be affected. So chronic kidney disease, it will increase risk for herpes zoster and its complication. As you know, those patients with chronic disease, their immunity will be decreased. So the risk for infection, it will be decreased. It will be increased, sorry. So also herpes zoster, it might accelerate the chronic kidney progression and cardiovascular events. So and vice versa. So this one, it will increase the chronic kidney disease will increase herpes zoster. Herpes zoster will accelerate the progression for chronic kidney disease and for cardiovascular diseases. Also, chronic kidney disease, it will increase risk of herpes zoster by 29% and its complication by 27%. So this is very huge, actually, percentage when we look at it. Now we will talk about other complication of the kidneys that it will be also increased risk of the shingles in general. So as you know, other option for kidney problems, for example, renal transplant, 8-fold will be increased. Peritoneal dialysis, the 3-fold will be increased. And those in hemodialysis, the risk, it will be increased by 35%, it will be increased. So all of these features in the renal problems, either in dialysis, hemodialysis, peritoneal dialysis, or those patients with transplant and immunosuppressant medication, it will increase the risk for the infection.
So it's the bidirectional relationship between herpes and all chronic diseases is very obvious. So, Dr. Dana, can you elaborate more about the relationship between zoster and kidney disease?
Yeah, well, herpes zoster and kidney is quite different. If we compare it with what I've previously talked about in diabetes and kidney disease, it's not just a temporary thing where if there's anything that goes wrong, you're going to correct it through changing the modality of therapy. But when we talk about chronic kidney disease and contacting herpes zoster, you're talking about survival rate. And here you can see through the graph on the right side that the survival rate drops throughout the 10-year survival period. So we're talking about the patient's long-term effect. And herpes zoster is associated with an increased risk of end-stage renal disease among patients with chronic kidney disease. And if we look at having patients with herpes zoster, chronic kidney disease, and diabetes, and how is that kind of a doubling effect happens to them. Also, the pharmacokinetics of the chronic kidney disease patients and how these kind of things affect the pharmacokinetics of drugs, increasing the risk of adverse events and drug-drug interactions. So patients with chronic kidney disease are suffering also from polypharmacy, and polypharmacy and reduced renal clearance will increase the risk of drug-drug interaction. The nephrotoxicity, and if we talk about the antiviral medications that are needed in that kind of phase, or if we're talking about the analgesics that patients will be needing because of the pain that they're going to suffer from, is also leading to more nephrotoxicity on the chronic kidney disease patients. And also they're going to be requiring more sophisticated dose adjustments according to their condition. So renal impairment affects the tolerability of treatment for herpes zoster, either directly or because of the polypharmacy, because of their current special condition. Also, if we talk about certain medications, like in cases of lupus nephritis, and we're talking about patients with medications that are going to be needing, that are going to affect their immune system. Also, these kind of patients have going to be leading more quickly to dialysis, or due to the complications, like we can see the treatment options here, patients are going to have more consequences and the burden with their disease.
Excellent. Thank you very much. And I think we made the case now of the importance of prevention and how it is important, especially in patients with comorbid diseases and older patients. So, Dr. Jawahir, I think it goes without a question, but why do you think that the recombinant zoster vaccine should be considered as a routine vaccination in our elderly population and patients with comorbidities?
So just to summarize, it will go to the landscape of the treatment of zoster. So you all know that the antiviral can be effective in 72 hours, and we might go longer for a specific population group like the stem cell transplant and solid organ transplant. But to prevent the complications, usually we recommend to start the antiviral as early as possible. However, some patients might present late, especially that the zoster will appear as only one or two vesicles that can be unnoticed. And when they have the post-herpetic neurology, unfortunately, there is not much that we can do apart from simple analgesia or a medication that is targeted for neuropathic pain. But we do have that prevention is of prime importance. We do have, prior to this 2017, we have the live attenuated vaccine that is mainly designed to prevent shingles and shingles reactivations in specific patients' populations. And then from 2017, we have the recombinant vaccine that also prevent zoster in patients older than 50 years or less, and patients 18 years of age with comorbid diseases underlying immune suppressing status. So recombinant zoster vaccine is very efficacious when it comes to prevent the zoster infection and also to prevent post-herpetic neuralgia. And it was studied in zoster vaccine efficacy study for those populations more than 50 years of age, and also in the zoster vaccine efficacy study of patients older than the age of 70. And the effectiveness of the vaccine is around 97.2 on all age group, and more than 95% reduction in the post-herpetic complications.
Please highlight this number again.
Yeah, just recall this number, 97.2. So 2 doses of the Shingrix vaccine is endorsed in all guidelines, and in particular also in the Saudi guidelines. So 2 doses of this Shingrix vaccine has a 4-time increase in the cellular immune response in comparison to only single shot vaccine. Most of the national and international guideline will endorse 2 doses of the vaccine at 0 and then 1 to 2 months in those patients population at whom they are immune compromised, such as patients is going to receive chemotherapy, biological treatments, solid organ transplantation, or HIV, and the dose can be given in a range between 2 to 6 months in the rest of the population without underlying immune compromising status.
Excellent. So beyond the efficacy that we have highlighted, Dr. Raneem, what else can you tell us about the Shingrix vaccine?
Okay, so beyond the 97% of efficacy, the vaccine actually is non-live IgE subunit. So you have an adjuvant system that can support the immune response. Is going to be better, more immunity for the patients who are older adults, 50 and above. The vaccine indication for the preventions of shingles and the complications of shingles like post-herpetic neuralgia. The indication, as we highlighted, 50 years and above. And on top of that, it can be used for the 18 years old at increased risk of herpes zoster, who are immune compromised, who are on immune suppressant medication that they're more prone to have herpes zoster shingles. They can be given the Shingrix vaccine. The other thing it's given in 2 doses, intramuscular. It can be stored in a regular refrigerator. This is very important for the primary health care that are scattered across the kingdom. So it's a regular refrigerator, doesn't need any advanced equipment. And also not contraindicated in individuals who are immune compromised, must not be given to any people who are allergic to any of the components or active substance of the vaccine. But it can be given to the immune compromised patient, and this is a game changer.
Okay. Dr. Adana, as a non-live vaccine utilizing the AS01B adjuvant system, as if I know what that is, how does this distinction affect your decision to recommend a recombinant zoster vaccine?
Yeah. How does it affect? First of all, knowing the advantage of having an adjuvant system or an antigen adjuvant system. Because here you can see through the graph that when we have the adjuvant, having just an antigen is the red line to make it just as simple as possible. And you can see throughout the months and having the second dose, what kind of a response rate you're going to get with the immunity. But having an adjuvant system, which is the antigen plus the adjuvant, and you can see how significantly higher immunity with the CD4 T cell response compared with only just having the antigen. So if you can make it just in a simple way, just imagine having the antigen is just like the engine, and the adjuvant system is the power jet for having it to work on so quickly and powerful. Another way to see it, this is just to show you the antigen part in the adjuvant. And the most important thing is it's, as my colleague said, that it's a non-live vaccine. So it also has a consideration of our complex cases of patients that we're not scared of having their immune response and what kind of effect it will happen. Keeping in mind that the efficacy and everything is going to be the accelerated, and usually it's going to be 2 doses, 2 to 6 months apart, and the given is each dose is 0.5 ml. But we do have an accelerated fashion or pathway for immunocompromised patients, whether because of their condition or because of the anticipation that they're going to start a medication that will lead to immunodeficiency. So we can have the second dose given within 1 to 2 months from the initial dose.
Excellent. So, in patients with chronic conditions, diabetes, cardiovascular disease, herpes zoster, prevention should be considered optional, delayed until complications, integrated into routine management only for hospitalized patients. Show us the QR code, please. Scan the code. Go back to the question. So, chronic conditions, diabetes, cardiovascular disease, should it be routine or not? Okay. Shows the answers. Now, can I ask a question? Who thinks it is optional? Raise your hand. It's okay. Now you still have lunch. Who thinks in patients with cardiovascular disease and diabetes, chronic kidney disease, it's optional? Of course, everyone has a choice in life, but who thinks it should be optional? The doctor shouldn't care if it's routine or not.
Probably those who had busy clinics.
Yeah, maybe.
Maybe.
Okay. I hope it was a glitch from the computer, but yeah. Okay. Good. So, Dr. Raed, now the recombinant zoster vaccine was studied in two large trials. How important is it to your practice when considering vaccination recommendations for elderly populations?
Yeah, thank you so much for this question. Actually, before answer this question, the recommendation before that to give the vaccination above age of 50. So in this, I will show you the study that done in two group of people, those above age of 50 and those people above age of 70. So basically, this is two large phase 3 clinical trials, also published in New England Journal of Medicine in 2015 and 2016. So this study is randomized, observed, blind, placebo-controlled, multicentral, multinational also. They conducted in the same site. So basically, the primary objective of this trial was the efficacy of these vaccinations in those above age of 50 and those people above age of 70s. So they give them two doses, as you know, 2 months apart, and they look for what's the result post the vaccination. So what's the vaccination efficacy for those patients? So it was 87.9 for 4 years post the vaccination in those people above age of 70, which is actually very significant actually results. They also talk what we call it post hoc analysis in those two groups, and they think that the vaccine also reducing non-PHN complication, like what we said before, the vasculitis, the ophthalmology features, and neurological diseases. Also, they try to look for that the efficacy of those vaccinations in above age of 50. So it was 93.7%, and they look for the vaccination efficacy above age of 70. It was almost 91.6%. And also they look for the vaccination efficacy for those patients in PHN above age of 50 was 91.2%. And they look also for the vaccination efficacy in those people above age of 70 in PNH, it was 88.8%. So it almost 90% above in all the results. Also, they tried to dig more in this study, and they tried to show how much those patients having prevention based by baseline condition. So those patients above age of 50, when they look at them, and those patients above age of 70s, so the vaccination efficacy almost the same and higher across all the medical condition, as you know. So they try to look for those patients having hypertension, dyslipidemia, also osteoporosis, sleep problems, prostate, hypothyroid, depression, cataract, and so on, renal problems, coronary artery disease. And they look for all of these, and they found it, it's almost similar in all other groups. Also, they try to look for the side effect, what's happening, the death. They are similar in the vaccination group and in the placebo group with no clinically significant. This is give us, after this study, that there is no safety concern was identified based on this medical condition presented at this study, and give us also hint that we can give it for any patient, whatever the baseline of his disease, safely. So giving for a huge group of patients above age of 50, above age of 70, with good clinical outcomes and without any serious side effect.
Excellent. Dr. Jawahar, how durable is this vaccine from the literature?
So in the same line, what Dr. Adda has just highlighted to you, which is the Zoe 50 and Zoe 70s, there are also a study that look into the durability, which is Zoster 49. It's an extension of Zoe 50 and Zoe 70, and the population were those patients more than the age of 50. And the primary objective of this Zoster 49 was to look into the efficacy against herpes zoster in the Zoster study. They also wanted to look into the efficacy of these 2 doses of the vaccine in a 4-year period of time. And they also calculated or measured the persistence of the vaccine inducing a humoral immunity by ELISA test and the cell-mediated immunity by T-cell intracellular cytokine staining and the safety. So to summarize it and not to add much to what Dr. Addahash mentioned, they wanted to look into the efficacy of Shingrix vaccine or the recombinant vaccine for 4-year follow-up. And also they wanted to look into the efficacy of 1 month after the second dose of the vaccine and how persistent is the humoral and cell-mediated immune response into those 2 vaccines. So for the primary endpoint and up to 4-year follow-up and even 9-year of follow-up, the efficacy was around 81.8%. And for the secondary outcome, which is the efficacy of the vaccine beyond 1 month from the second dose of the vaccine, it is around 89%. So one thing also, or a number that to recall, that the Shingrix vaccine or the recombinant vaccine is effectiveness can last up to 11 years by 87.7% with no safety concerns.
Excellent. So I think we highlighted the numbers several times. I hope your seats are more comfortable than ours. My God. So I'm not used to sitting this long. Can you put the QR code, please? Back to the question. So again, which of the following best describe the efficacy of recombinant zoster vaccine in preventing herpes zoster in adults above 50? The efficacy, we talked about a magic number several times. Is it only 50%, 60, 70, 90% efficacy across age groups, or decline significantly than that? Please choose. Don't hear. Huh? Yeah, presented several times, and we mentioned the numbers several times, and we highlighted seed several times. Show us the answer, please. I'm gonna leave. Yani, who chose? We said 97% several times. Okay. Is there a language barrier here or something?
Online.
Okay, it's definitely above 90%. It's very efficacious. Okay, moving on. Dr. Dana, so now we've been using it for a decade. It's very efficacious. How is prevention with this intervention in your experience and practice?
Yeah, so if we're talking about a vaccine and we're promoting for protecting our patients, how long is he going to be protected? That's the main question. So here we're talking about the durability or the longevity of the vaccine. According to the Zuster study of 049, the long-term persistence of humoral immune response. So we're going to be talking about the humoral and the cellular response and how persistent it is throughout a decade of 10 years. So here you can see that it's still, you could go at the far left and see the pre-vaccine where patients were not vaccinated and how is the antibodies levels. And then after the vaccine and throughout the 10-year period. And you could see that it is having an antibody concentration that is persistent of more than 5-fold above the pre-vaccination level up to year 10 after the vaccination. So it's not just a spike of having a protection and then it weighs down. It's a persistent level. And if we talk about the cell-mediated immunity with the T cells, the same thing. It has a long-term persistence of cell-mediated immunity. And you can see also, if you compare it with the pre-vaccination and then after the vaccination, it has more than a 6-fold increase throughout the 10-year period. So through that, I know that my patient is going to be protected for a long period and having the effect of what I need.
Dr. Raneem, the recombinant zoster vaccine has demonstrated a very good safety profile. How does that influence your decision when you prescribe?
It definitely influenced my decision, especially for older adults. Safety is the primary consideration for them. So we deal with patients who are 65 with multiple comorbidities. They have a lot of medications on their list, polypharmacy. So you're building a medical plan with them to stabilize them and make sure that they're not having any complications or side effects. So giving that this vaccine is given in 2 doses, you have to make sure on top of their medication, their compliance with the vaccines, that they get the first dose and the second dose. And based on the ZOE1 and ZOE 50 and ZOE 70, you can see that with the second dose received from the vaccine, 95% they were compliant. And 96% of the subject received the placebo, they were also compliant. So they were compliant across ZOE 50 study, and even goes also with the ZOE 70, 94% of the patients, they received the vaccine, the second dose of the vaccine. So the compliance rate was more than 90%, even with the patients who had grade 3 reaction. So looking at the incidence of any side effect or reactions by age group, you can see that the most common reaction is the local reactions on the site of injection, and it's transient. You can see pain, redness, swelling on the injection site, and it did not, the median duration of up until the resolution of the symptoms is 3 days of any grade. Looking at the general side effects or events that associated with the vaccines is also transient, also with the general events. And the duration were 3 days of any grade, looking at the fatigue, malaise, headache, shivering, and the most common ones that we usually see is the fever and fatigue for the population. For the ZOE 50 and 70, as Dr. Jawahir was looking at the data, they looked at 4 years data after the vaccination, and they were looking also, besides the compliance and side effects and safety for the vaccine. As you can see, there were minimum side effects from local or even from general events. And as you can see, for the post-herpetic neuralgia, the prevention was very high. Even 4 years after the study, the population were given the vaccine. No vaccines-related side effect or death, and only 5 patients with the herpes zoster has related complications, as you can see in the table. So the overall incidence of side effects and death were similar between the placebo and the vaccine itself. And so the overall side effect and safety profile of the vaccine was great. and the local reactions and the general events were actually transient within 3 days period, it's gone.
Excellent. So moving on to the fun part, if it is fun. Which of the following best describe the safety profile of recombinant zoster virus? Can you show us the QR code? We'll go back to the questions. Okay, back to the question, please. So, safety profile associated with significant serious adverse events. I think Dr. Raed showed poorly tolerated in adults, older adults, generally well tolerated with mainly transient local and systemic reactions. I think Dr. Ranim highlighted that very well. Requires hospitalization monitoring after admission. Why are most of the questions answered C?
This is one of the rules that I told my student, if you don't know the answer, go for C.
Go to C. Yeah. Okay, so show us the answer, please. Yeah, I give up, but we're best. So it's definitely generally well tolerated, and transient local and systemic reactions is the major side effects. Okay. Now, with all the studies and evidence, it made the recommendations. So, Dr. Jawahir, how integrated are these recommendations into your practice?
So the vaccine of the Shingrix or the recombinant zoster vaccine is now endorsed in several guidelines, including the Saudi MOH guidelines. They endorse 2 doses of the vaccine. It gained access to the Saudi guideline for HIV treatment, and also in the rheumatology, Saudi Society for Rheumatology guidelines as well. It's part of it now, the 2 doses of the zoster vaccine.
I think there are more guidelines and local recommendations, Dr. Raed, if you want to highlight on those, please.
Yeah, thank you so much. I think also there is a lot of local guidelines they recommend. So Saudi Thoracic Society, they recommend this vaccination for those adult patients with chronic respiratory diseases. So it's very recommended now to give it for them. Also, Saudi Heart Association, they recommend the vaccine for adult patients with cardiovascular diseases. So now all that local guidelines also, in addition to international guidelines, they recommend to take this vaccination for those patients with chronic diseases.
Excellent. So, as you said, I mean, it's just to stress and highlight, as you've seen in cardiac diseases, in rheumatologic diseases, respiratory diseases, all chronic diseases, and Ministry of Health for patients above the age of 50, is just to emphasize the importance of this vaccination. Dr. Odana, what about international guidelines?
Well, international guidelines are talking the same as the local. The message is clear. If we talk about the CDC recommendation, all adults aged 50 years and older should be protected. And even adults 19 years or older that are immunocompromised, whether on low-dose immunosuppressive therapy or that have recovered from an immunocompromised illness, also should be protected. We can see throughout internationally, you can see throughout the map that if we talk about diabetes per se and diabetic patients and should they be protected or not, several countries specifically recommend immunization of people with diabetes. And again, it's the same. We're talking about patients that are 50 and above, and the other exception of the younger ages if they are immunocompromised. Guidelines like one of the most favorite ones as the ADA, Standards of Medical Care in Diabetes, recommends also the same, the 2 doses in people with diabetes aged 50 years and older, and even if they are previously vaccinated, and also having all people with DM. Keep in mind, everyone that is diabetic, 50 years and older. Guidelines also for herpes zoster prevention with chronic or cardiovascular disease. Again, it's the same, patients that are aged 50 and above. And you can see throughout the map that multiple international guidelines are recommending that. So it's whether we're talking about, I think, local or internationally, it's all the same message. Patients got to be protected.
No, I think scientifically it's well sound. People know about it. Unfortunately, recently there has been a lot of talks about vaccines in general, overall and worldwide, with and against, and that in lots of topics actually in medicine, not just vaccination. Dr. Raneem, how do you see the role of the healthcare practitioners in empowering and improving the vaccination programs and increasing the trust among patients?
So, as the Vision 2030, prevention before treatment, and I think it's a mandate on all healthcare system, on the healthcare practitioners across the country, whether they're cardiologists, infectious, endocrinologists, gastroenterologists, all we have a mandate to make sure that every single patient has a prevention measures within our system, within our practice. And as you can see in this slide, if the patient sees a advertisement for the vaccine, or if they see the vaccine written somewhere, the effect or the impact is 25% of those patients will go actually to their physician and ask for the vaccine. So it's only 1/4 that they will get the vaccine. But if the healthcare or the physician will speak with the patient and have it as part of their integrated care plan, this is a very transformative effect, actually. That's going to be 3 times higher for them to take the vaccine, which is around 74% will accept the vaccine and will take it. So the physician does impact the decision, the patient's acceptance. And there is just a brief mnemonics that we usually advise to use is the DOS. D is for danger, O for opportunity, S for solution. The danger is to highlight the urgency of the matter and framing the situation before fixing the issue. Opportunity is what does the potential look like, laying out the benefits for the patient, and the solution to offer them the vaccine, to offer them the solution to prevent the complication and the disease itself. This is just a scenario, an example for the healthcare practitioners to show them how exactly they can carry on the conversation with the patient in their clinic. This is a patient that you see in your clinic. He's more over than 50 years of age. He had chicken pox in his childhood. You just go and tell them, I know that you're 70 years of age. You had chicken pox when you're young. This means that the virus is still asleep in your body. It's in your nerves. And by aging with immunosenescence, with aging and the immune system that naturally declines with aging, that means that this vaccine might reactivate. And the reactivations of this vaccine by time, it may be very painful and cause complications and affect your quality of life. Then you can set the goal that there is an opportunity here that you can prevent this disease, to protect yourself from the pain, from the complications. And based on your record, you are capable of taking the vaccine and recommend this for the patient. And then you start giving the patient the solution that the vaccine is 2 doses, it's given in the intramuscular, and talk about the safety and the efficacy of the vaccine to give the full protection. We talk about the vision, especially for the geriatric population, about life expectancy. We want to live longer and healthier, actually, and more with healthy lifespan, that I would say, more than longevity, adding just years to the patient rather than having a healthy or adding healthy years to the patient's age. And prevention and vaccine is one of the important measures to do for those kind of patients.
Exactly. Thank you very much. It's the quality of life that we're looking for, and that's why we're having all this. So one more poll before we go to the answer. According to evidence, how does physician recommendation impact patient acceptance? We just mentioned that of RZV or recombinant zoster virus, Shingrix. Again, all the answers I see, and it's very good. So against yeah خلاص هذا كلها سي وبرضه بيغلط. C. If anyone answers A or B, please go check your hearing. Okay, back to the question, please. Okay, answer. Please, 100%. 64, my God.
They're hypoglycemic now.
Yeah, they're hypoglycemic.
Maybe.
64%. اللي حط الدبل هو مو سامع سي ولا he doesn't believe us. Maybe he doesn't believe you. Maybe he has other data. Okay. طيب. Next. Now we came to the end, alhamdulillah, of the lectures. It was a very nice overview. ما تبغى summary? Yeah, I'll give you a summary. It was clear, but we can give a summary before we take the questions. Let me see it here better. Varicella zoster virus reactivation in adults leads to shingles, which can be associated with complications, most predominantly post-herpetic neuralgia. Herpes zoster risk is significantly increased with age, specifically after 50. Nearly half of herpes zoster cases in Saudi Arabia are older than 50. And herpes zoster risk is increased in the presence of certain comorbidities such as diabetes, chronic kidney disease, cardiovascular disease. The available treatments for post-herpetic neuralgia are limited in clinical practice, unfortunately, so we don't have much to do for post-herpetic neuralgia. In clinical trials, recombinant zoster virus achieved nearly 97% of efficacy in all patients 50 years and older. Global guidelines recommend recombinant zoster virus for all adults above 50 and older. National Saudi guidelines recommend 2 doses of recombinant zoster virus 2 to 6 months apart for all adults above 50. And healthcare practitioners' opinion highly influences patients' acceptance for a vaccination. Okay, so again, I would thank our marvelous speakers for their talks and discussion, and you as well. Can someone help me here? You can, but it's too early. Let's take the questions first. It's closed here. Someone here, please. Yeah, that's good. I'm talking about the yes, here. Questions. So let's take some interesting questions that came from outside, and if there are any questions here as well. Dr. Raed, can shingles present without pain?
It's very rare to come without pain, but in acute, in first phase, usually it's not came with pain. Usually it's general symptoms, came with headache, fatigue, for usually first 2 to 4 weeks. Then after 2 weeks, for 4 weeks, they came with other symptoms, like we mentioned before.
The rash and other symptoms.
So for answer for this, yes, but most likely more than 50% of them, they came with PNH. Yeah.
Nice. Excellent. Yes.
Yeah. So immune compromise, especially like solid organ transplant and stem cell transplant, they can present atypically. So sometimes they would present with the pain only without the presence of vesicle, or sometimes they can present with the vesicle and the pain will come later on. So special considerations in this population group, especially for the family medicine or primary health sectors, that the immune compromised individual, they can present atypically.
Excellent. Now, yeah.
Even for the older adult population, they might present atypical.
Yeah. And I think the immunocompromised and elderly, they present with lots of atypical presentations in general. Dr. Jawahar, can Shingrix be given with other vaccines safely?
Yes. So most of the time you can give 2 to 3 vaccines at the same time, and that should not affect the development of antibodies against them or the immunity. Yeah, so we can.
Does it increase the chance of having side effects or local pain or anything?
No, like
No?
increase the
Can give
chance
it
of
in
getting the
different
pain,
places,
okay,
yeah.
but not the
Yeah.
others. Yeah.
طيب دكتور Raneem, post-herpetic neuralgia is common. What are the recent and best lines of management? And I think we said there's not much. How would you manage this prevention? Yeah. So if you have a patient who came with the post-herpetic neuralgia, how would you manage that?
It's really difficult with the pain, especially as I told you, and it's frustrating because with older adults,
Yes.
even the pain medication that we give, usually we try with like something acetaminophen, but then the other medication that's given for the nerves are not the first line therapy that we usually use in older adults because they come with their own set of complications and side effects for the elderly. Given that with aging, the pharmacodynamics and pharmacokinetics, they change. So what I would always go, even if they have post-herpetic neuralgia, I would give them the vaccine also to prevent further reactivations.
Okay, Dr. Odana, interestingly, the person who's is asking here, he says I'm a family physician, although it doesn't matter here. Unfortunately, and then we wish him all the health, he had herpes zoster at the age of 47. And ophthalmic herpes zoster. His question is actually different. He's asking, all the recommendations are saying 50 and above. Are there any patients who we would recommend before 50 to receive the vaccine?
Yeah, clearly stated through all local and international guidelines, 50 and above for patients as a prevention, but also from the age of 18 and older. And some also guidelines stating 19 years and older for patients that were going through any immunocompromised state, whether because of a disease or a medication that caused that.
Yeah.
So yes, patients can, and it can happen even in younger age.
It can.
Yeah.
Yeah. Now we did highlight that. Yes.
Yeah. I want to add one point also. Sometimes healthcare providers, it's one of the people that they might recommend some of the vaccine to be taken earlier. So not only immunocompromised. I think he talked about himself that he's healthcare providers. I don't know if he have another.
Yeah, but just being a healthcare provider is not a risk for disaster.
No. I mean, the risk for all the infections.
Yeah, infectious. Because, and this probably highlights the coming question. It's a reactivation. It's not an infection. So someone is asking about the contacts. I don't think there is a risk for a contact because it's a reactivation.
No, zoster in most of the time is reactivation for those, but specific consideration for those who do not have varicella from the
Who did
first,
not have
or who
varicella
did not
disease,
receive
yeah.
the vaccine and they never get chickenpox. This is probably very risky for them. And it depends on whether they are immune compromised or immune competent. The outlines of management is different. Yeah.
Yeah. Any question here? No one? Yes?
Second dose, or we repeat the we give 2 doses.
The recommendation is 2 to 6 months. So you're saying after 6 months?
He came
Yeah.
late.
More than 6 months,
Yeah, you just give the dose.
the second dose.
Second dose only.
You don't have to count from the beginning.
Ah,
Yes.
Thank you.
But there's no time limit. Let's say he took it once and then, yeah. Okay. There are a couple of questions here about a booster dose. Is a booster dose required at any time after
So-
10 years or?
So far, there is no recommendation
Yes.
about the booster dose because again, the efficacy lasts up to 11 years. Yeah.
But we don't know after 11 years, should you get it?
So the recommendation is still
Yeah,
not yet.
we'll see after 11 what happens to people.
Let them take the vaccine first before they reaches the end.
Exactly. That was it. There's another question here?
Yes. If the patient take the first dose and with hypersensitivity reaction, can continue the second dose or stopped?
If he has a reaction to the
If
first.
reaction or anaphylaxis, no, we
Yes,
don't
yes.
recommend.
Yes.
Some of the immune compromised
Well,
individuals, they
give-
might go to
Take the second
desensitization.
dose or stop?
No, you stopped.
So again, they keep on asking if someone forgets to take the second dose and he comes after 2 years, should we just give him the second dose? Yeah. I'm taking from here and here.
Hello, the question is for the recurrence. even though you have 2 booster dose, vaccines complete, is there possible for reoccurrence?
Recurrence, it's
Yeah.
very intensively immune suppressed.
Yeah.
Yeah, so they did not mount the immunity from the vaccine, which is very well known, not only with the Shingrix vaccine, with other vaccines as well.
So there is recurrence.
Yeah, but the percentage is not very clear. We don't have data on that. But if they are intensively immune suppressed or they got chemotherapy or other, they can reactivate, especially for those who receive what we call it a WBC irradiation or bone marrow irradiation, they lose all the immunities.
Again, so what will be the treatment then?
So
Another vaccine?
yeah, if they are intensively immune suppressed, we revaccinate them 6 months after the stem cell transplantation or whenever their immune system is expected to recover.
So it means that not only for 2 doses, it could be if there is recurrence, we can do again vaccine.
Not for the regular people.
Yeah, the immune.
yeah.
We are talking about
You-
sorry, have
usually-
cancer. Yes, this one.
In most of the guidelines, you can revaccinate afterwards.
Oh, thank you. And then the second question is for the it should be 50 above, 50 older to be vaccinated in the shingles. So the older is how old is the old?
As old as you can.
I mean 86, 91, it can
Right.
be.
Yeah.
Okay,
No
thank
limits
you.
on the age, but if it's going to be started earlier, so it's more
Yeah,
than
yeah.
18 with comorbid.
Yeah, but if she did not, until now, she's already 62, she doesn't know about this. So if I'm going to introduce, it's also be possible.
Yeah, we vaccinate.
And then 2 to 6 months still. Thank
That's
you so
correct.
much.
Yeah, 62 still young. So there's this was a question also here about the upper age limit. So there is no upper age limit. Any other question here? Right. Now they were talking about, I don't know, they health co-workers keep on mentioning, I don't think healthcare workers are at any increased risk, so it doesn't matter. You should be, where is it? First dose, if your second dose. So we did show that with the first dose, there is some protection, even if they refuse the second dose. But again, the second dose provides more protection than the first dose. Guillain-Barré, has it been reported?
Guillain-Barré is reported with most of the vaccines, so there is no specific particular vaccine that is very well known to cause Guillain-Barré, no.
Okay. I think these are the most of the questions here. Now, to me, and then I think this probably needs some update. We keep on saying 50 and above, and saying those with comorbidities who are above 50. That did not add much. So I think in future we need to start differentiating between those who really have comorbidities and those who are above 50. If I'm going to give it above 50, then that's it. If you have long-standing diabetes, for example, I don't know if type 1 diabetics should get it before the age of 50 if they have it for 10 or 15, 20 years. Those who have early chronic kidney disease are on dialysis, those who have chronic lung disease. I think with time and more safety measures, or at least more being comfortable with the vaccine, we might recommend it earlier for those with chronic diseases. Great. So if there are no more questions, show us the survey, please. Please scan this and give us your feedback. It's very important to have your.
Can
you
I
have a
ask one
question?
question is,
Yes, go ahead.
for above 60 years patient, diabetic, and post BCI with stenting, if any precautions or contraindication to give this vaccine?
It's actually recommended to be given. There are nothing.
No time after BCI can be given even after a few days?
Or the, he means
You mean inpatient immediate post PCI? Yeah.
it's actually recommended, yeah.
Yeah. Actually, now the argument, the question is always whether to give it in hospital or after discharge.
Yeah.
It's more recommended now to give it in hospital because of the compliance and early protection.